Wonderful. Now my slides don't want to go. This is really weird. Dr. Crowley, you can see my screen, correct? No, I don't know what's going on here. So I will just get started. All right. Good evening. Thank you, everyone. I'm so sorry. Um, the slides are not working correctly, but I do want to get started. Just wanted to make a couple of announcements before we get started. So welcome to tonight's presentation of emerging treatment options for lupus. It's going to be presented by Dr. Angela Crowley. Before we get started, I just wanted to welcome everyone to our first educational event of 2026. My name is Lisa Klaslow. I am the Community Relationship Manager at the Lupus Society of Illinois. I am also the person that sent you multiple email reminders about tonight's event. I'm so sorry. I had a little bit of an Outlook educational experience today, and I'm sorry you guys all had to receive that link a few times, but we do really appreciate everyone jumping on tonight. Before we get started, I just want to make a couple quick announcements. About tonight's presentation, this event is an educational and informational purposes only and serves to benefit our mission. The Lupus Society of Illinois does not provide medical advice or recommendations. This information should not be substitute or replace expert medical care. Before making changes to your medical care, consult your qualified healthcare professional familiar with your medical condition and health status. This event is being recorded and will be archived on the Lupus Society of Illinois website, and we do have a YouTube channel. Um, just a couple cute new things as a new year starts. We often find that people are looking for support. We do have multiple support group meetings that meet every month. So if interested, or bi-monthly, if you are interested in joining a support group, please reach out to me and I can connect you with a leader that has a day and a time that is good for you. I also did want to announce that we have officially launched our Western Suburbs Walk site. Our walk this year is going to be August 22nd in Naperville. Um, we are promoting an early bird special, so if anyone wants to register from now to the end of February with the coupon code early bird, you'll get $5 off registration. So the $25 would be $20. That's adult registration only. And anyone who starts a team as team captain and gets one person to sign will get an LSI pom-pom beanie mailed to their house. I'm also going to be starting to head up the committee to plan the walk. So if anyone is interested in kind of helping behind the scenes, kind of learning about the walk and helping get some creative ideas and how to make the fun walk personal and fun, please reach out to me. We are going to have our first meeting on February 10th, so I am looking forward to that. We have a 2026 Bank of America Chicago Marathon team. All our spots are filled, so we're very excited. Usually this time of year, we're trying to look for runners, but we had a really great turnout. We're super excited about our runners, but if anyone is looking for an open spot or looking for more information or wants to get on a wait list, we have all those available. So reach out to Mary or me to give you some more information on that. We are always looking for volunteers and internship opportunities. So if you know anyone who's looking to volunteer their time, please have them reach out. And again, we want to just thank everyone who was able to join us tonight. These educational events go on because of donations and great people like you who come out and support us. So we just want to thank everyone again. Um, that is all I have, but I do want to now introduce, hang on one second. Want to introduce Dr. Crowley really quick. So I'm going to turn this over to Dr. Crowley, but beforehand, I just want to let everyone know Dr. Crowley received her medical degree from Texas A&M Health Science Center College of Medicine, followed by an internal medicine residency at the University of Utah. She completed a fellowship in rheumatology at the University of Virginia and then received additional training of rheumatology in Auckland City Hospital in Auckland, New Zealand. Wow. She is the Chicago chapter leader of Association of Women in Medicine. Dr. Crowley currently is the owner of Willow Rheumatology and Wellness, where she practices rheumatology and is a private investigator for many clinical trials. So with that being said, I am going to flip this over to you. And are you able to share I'm going to stop sharing my screen. Okay. All right. Thank you, Dr. Crowley, and you are good to go.
Okay. Thank you so much for having me. There's a lot going on in lupus right now, so I'm really excited to talk about some of these emerging treatment options. So thank you for the introduction. I have a rheumatology clinic in Willowbrook, Illinois. And let's see. These are my disclosures. So it is sort of a science heavy talk, but I'm going to break it down for you so it's easy to understand. But I think that people really like more information rather than less, I've learned. And so I'm going to give you a lot of information on the slides, and I'm happy to take questions at the end. So outcomes in lupus are are not as good as we would like. You know, despite approval of some biologic therapies, outcomes overall do sort of remain poor in lupus. And if you look at studies, here's one example looking at 3,300 lupus patients. A third of those patients did not achieve their treatment goals. And in people who aren't reaching remission or low disease activity, we know they have worse outcomes. They have irreversible organ damage, higher chance of dying. We know that in patients diagnosed with lupus, 50% of them will have that end organ permanent damage at 5 years after their diagnosis. So I think it's really important to try and treat lupus really aggressively early on and make sure that we're not having any permanent damage. And you'll see that sort of throughout my talk about how we're learning more and more that how important that is. This is the EULAR guidelines. So it's the European League of Rheumatology, and they came out with these guidelines in 2024. The American College of Rheumatology came out with some guidelines last year, which are pretty similar, but they don't have as nice of a graphic. So I really do like kind of sticking with this one. And I'm going to walk you through it because everything is important here. If you start over on the left, you'll see that the general measures for treating lupus start with sun protection, exercise. You definitely don't want to be smoking. Have a balanced diet. You want to be up to date on all of your vaccinations. You want to be controlling your blood pressure, your lipids, your glucose well, because what people with lupus end up having problems with, or what they end up dying with, a lot of times is heart disease, because the lupus really increases the risk of having heart disease. So it's important that we address all of their medical problems and not only their lupus. And then if you look over at the bar on the right, it's recommended that we're treating people to remission. And these are just different ways to measure remission. There's a SLEDAI score. We want them to be on their hydroxychloroquine or Plaquenil, if at all possible. And then we don't want them on more than 5 milligrams of steroids a day, long term. Of course, sometimes people have flares, they have to be on a higher dose. But if a patient is still on more than 5 milligrams of prednisone, you really should be trying other treatments to try and get that dose down. And then so moving back over to the middle of the graph, there's mild, moderate, and severe lupus. Everybody, no matter what, should be on that Plaquenil or hydroxychloroquine. It's so, so important. It's an extremely safe medicine. It really lowers rates of progression of lupus, lowers rates of kidney disease, lowers rates of death. So that's sort of our baseline treatment. And then on top of that, sometimes we do use steroids because they work quickly, but you don't want to rely on that long term. And then, so in people who have mild disease, who still need treatment on top of that hydroxychloroquine, you can use any of these first line. This is methotrexate, azathioprine, mycophenolate, and then two biologics, anifrolumab and belimumab. And so what's new with this is that you can use those biologics right away. You don't have to go through a bunch of different pills, which may have side effects or may not work very well, like we used to do before we had these biologics. And then when you move over to more severe disease, there's other treatments like cyclophosphamide and such that can be used as well. This is a treatment timeline. If you look starting back in the 50s, they did have the hydroxychloroquine and steroids, but that's pretty much all they had. And then moving in the 1960s, NSAIDs, azathioprine, and cyclophosphamide. And then there's this huge gap where we had nothing else. It's like mycophenolate is another, it's a pill, it's a DMARD. It's good. It's less toxic than the cyclophosphamide, but it's just another pill. It wasn't until March of 2011 that Benlysta was approved. And if you also look at sort of the other pills like NSAIDs, those aren't FDA approved for lupus. So this was really, one of our first medications is FDA approved for lupus. And then shortly after that, we have our anifrolumab or Saphnelo, which was approved in 2021. Because I shouldn't say shortly, because it was a gap of 10 years. And then since then, the only other medicine that we have is this obinutuzumab, which is approved recently for lupus nephritis, but not just for your regular lupus. And so in the span of all of these, past 20 years, that's not a lot. When you compare it to our other medications like psoriatic arthritis, we're having biologics come out several every year, new ones. It's really difficult to get medications for lupus approved. So I liked this graph that sort of asks, how do we do better? And we need to do better research and better trials to help get these medications out for patients that are needing new and different things. These two biologics are great, but they don't work for everyone at all the times of their disease. And so those treatments that we're trying to get more out on the market, we have to have them centered around the specific patients that we need, that we do need more biologics that are targeted. And that has to be evidence driven. And we have to pay attention to what we're trying to treat, because if they don't make those endpoints correct, then it's hard to meet them. And then the medicines, keep getting declined to be approved. There have been a fair amount of trials over the past several years, but they don't end up getting FDA approved because they're not able to show how effective they are in the way that they design the trial. And so this is a little bit out of order. I'm going to come back and do those two slides. First of all, I want to talk about types of trials. There's interventional studies and then observational studies. The interventional studies are what we do when we're testing new medicines that are coming out, new ways to prevent, new ways to treat disease. And in these, usually patients are involved and they're assigned to usually the real drug and then a placebo. And then we monitor how well they do so they can compare to see how well the active drug works. And then we also have observational studies. And those are sort of database driven a lot. We're sort of treating patients as we normally do. And then we just keep really good records and different databases. And we are able to learn a lot from that about the natural history of the disease, how well those medicines that are already being used and already approved are working. And so we do both of these in our clinic. But those interventional studies have different phases. So I want you to kind of understand that when you're thinking about the trials that are going on. Phase 1 is the first phase, and these are really small. These are about 20 to 100 patients. And this phase of the trial is really about safety. They're just trying to figure out, is this going to be acceptable to use in humans? It's the first humans that get the drug. They're looking at the levels of drugs, how a lot of times they're admitted to the hospital and they're checking their blood, even like every hour, even after they get the medication, to try and learn more about how this is going to work in people, prove that it's safe, and then they can move on to phase 2. So phase 2 can involve more patients, several hundred patients. And in this phase, they're looking at efficacy, and they're also looking a lot at the most effective dose. So they may try sort of a high dose, a medium dose, a low dose, and figure out what's the efficacy when you compare those compared to the types of side effects. So a lot of times they'll end up sort of in a medium dose, or they'll decide how they want to move forward after that. So then phase 3, this is sort of the meat of the phase of the trial that's, I think, is really important and really excited. So these medicines have been proven to be safe. They found the dose they want. And so this is the big trial that we're going to do to try and get it FDA approved. So with this trial, we're looking at how effective is the medication, and then we're also studying its safety. These can have hundreds to thousands of patients, and they can last usually at least a year, but a lot of times they'll keep going because these are really some of the earliest patients that have had the medication, and they may stay in the trial until the drug is FDA approved. They may even keep them. Some trials have been going on for 5, 6 years because they can use that data to show long-term safety. So then at the end of these trials, all of that data is presented to the FDA to try and get FDA approved to use in on the commercial market. Phase 4 trials usually occur after a treatment's already been approved. So sometimes the company or the investigators want to come back and look at using this medicine maybe in a different way or in a specific group of patients, or to answer a question that we might not know about from the initial phases of the trials. But it's not that you're testing out a medication that's not approved yet. Okay, so I wanted to start with the phase 4B early trial. This medicine, belimumab, or Benlysta, is already FDA approved. However, I'm really excited about this trial because what they're doing with this is they're going on that assumption of about 40% of patients, I think I mentioned 50, so somewhere between 40 and 50 patients have that end-stage organ damage within 5 years of diagnosis. And that's due to both their uncontrolled disease and also a lot of steroids that we've used in the past. So those people are dying earlier, they're having more complications. And so what we're doing with this trial is we're trying to come in and use this biologic, belimumab, earlier in the course of the disease. So within 2 years of someone being diagnosed, we're going ahead and adding that biologic, and we're not waiting until they've tried a million other things, 5, 6, 7 years later. And then we're going to look at how those patients do, and long term, compared to patients who haven't been, receiving, compared to the baseline of patients who weren't getting biologics earlier. And I think we're going to see some really good information from this. So I'm excited about that one. This is a really scary looking slide, and you don't need to understand it, but I think it gives you the breadth of everything that's being studied right now for how you can treat lupus, because there's many different ways you could go about it. If you look in the middle, we have B cells and T cells. A lot of lupus treatments have been focused on the B cell, which is a part of your immune system. All of these things, the CD20, CD19, those are receptors on the B cells. So all of these medications that you see over here are medicines that are in trials or have been in trials that go and they attach to those receptors and try and block that B cell somehow to try and take down the activity of the B cell so your immune system isn't overacting and trying to attack yourself so much. Another part of your immune system is your T cells. So there are some medications that are working to try and calm down T cells, or to try and calm down the sort of the inflammation and the signals between B cells and T cells, because they do sort of talk to each other. And then once the B cells and T cells start sending signals out to try and create inflammation in your body, so you can look at the bottom, B cell goes to plasma cell, and then that makes some antibodies. Those make immune complexes. And then those are the things that are attacking your kidneys or attacking your skin, causing the problems that you're having. So those can be blocked all along the way. So I'm not going to go through every specific medicine that's listed here, but it just shows you how much work is going on to try and stop lupus at multiple different points in the immune system. So I'm going to go back to the other one. I don't know why this got out of order. Oh, I think because this is the one that's already approved. This is that obinutuzumab, so that's why I put it up first. So because it is already FDA approved, I just wanted to cover that a little bit more. It's only approved for lupus nephritis. That was in October of 2025, so it's brand new. This is on the type 2 anti-CD20 receptors to those B cells. So it's a stronger ability to induce that direct cell death and the antibody-dependent toxicity of those B cells. And then I did want to share those trial results with you. I know it's pretty scientific looking, but if you look up, it's pretty straightforward. If you look up in the top left, you can see that patients, 50% of them got the placebo, 50% of them got the real drug. And then if you move over to the right, you can see the difference between the placebo on the bottom, meaning that was sort of the fake medicine, if you will, compared to the actual medicine, the obinutuzumab. And that's the function of our kidneys. So the kidney function kept going down and people not getting the medicine, and it did not drop down in the real drug. So it did appear to be effective. It did get FDA approved. And so we're excited to have that in our arsenal to treat lupus nephritis, which is the kidney disease with lupus. Okay, moving on. This is another medicine that I'm really excited about. This is the phase 2 data. So this was that data where they're looking at some dosing, they're looking at a little bit of efficacy, and you can see here. So you'll see, I'm going to show you still a lot of treatment results, and they're all pretty similar. You can see that ianalumab is the active drug on the top line and then the placebo on the bottom. And you can see how much of a difference there are. This is treating, looking at SR4, which is just one way to measure how active someone's lupus is. So you can see there's a big difference. Only about 20% of people got better with the placebo versus somewhere around 70% of people with the ianalumab, and that's at 28 weeks. So they move forward with the phase 3, which is what's going on right now. That trial is called Sirius, and that one just finished getting all the people in that they need. So now we're going to follow them for the next time period to see how they do. And this is the way that it works is it has a dual mechanism, which is really interesting. So it attaches to the BAF cells on B cells, and it works both against lowering B cells and lowering those BAF signals. So I think it's going to be really strong, if you will. I think it's going to be really effective, but we'll have to see how the trial ends up. Moving on to the next one, upadacitinib. This medicine is also called Rinvoq. You may see it advertised on TV. It's approved for 9 or 10 other diseases. So it's already approved for rheumatoid arthritis, psoriatic arthritis, atopic dermatitis. It pretty much seems to work for everything. So sure enough, they decided to try it with lupus. And this is the phase 2 results. This trial's already over. They had 340 patients and they compared it to placebo and did show, I'm not going to read all this to you, but you can just see that the endpoints, people did much better with the upadacitinib dose compared to placebo. They had lower amounts of flares, and they looked at them through about 48 weeks. So they did move forward to their phase 3 trial. This is the Select SLE. This one is almost full of patients, and so it should be having results in the next year or so. This is a phase 3 trial to look at the safety and efficacy of upadacitinib. And so the way that this works is a JAK inhibitor. And so JAK enzymes work pretty high up in the immune system to cause a lot of signals that create inflammation. And so again, it works for a lot of diseases. It looks like it's going to work for lupus too. It's just a pill, which is nice. And we'll wait for the results on that. Obeliximab is another exciting trial going on. So it already did finish its, I'm sorry, it didn't finish its phase 2. The phase 2 is currently enrolling. So this is called the Sunstone trial. Again, all of them are pretty similar as far as they're comparing them to placebo and just looking at endpoints with lupus. And the way this works is by binding to those CD19 receptors on the B cells and also the Fc gamma receptors. And this was totally different than something like rituximab, which rituximab, some of you may have already tried. It's an old medication. It was tried in many trials for lupus and never actually got FDA approved, but it does have some efficacy, so we do use it sometimes. The way rituximab works is by blocking out those B cells, sort of kills them off, and that lasts for 6 months. There's a lot of downsides to taking out your B cells for 6 months. You get pretty immunosuppressed, risk for infections, and then if you get an infection, there's not much else you can do because that's in you for 6 months. And the way this one works is sort of just by turning down those B cells and not totally killing them off or depleting them. So that has a lot of advantages as far as safety. This is a nice little picture of it over on the right, looking at the bottom part is sort of one of those B cells, and then you can see these receptors on top. The obeliximab is this Y-shaped thing on the top that's going and attaching to that. And so it doesn't totally disable it, it just turns it down for a little while. The nice thing about that is that if you stop the medicine, you have a rapid recovery of your B cells. Your immune system can come back really nicely and quickly. And there's also some benefit to having this this injection, say, I can't remember how often it is, but it's probably something like every week or every month, doing it pretty often and keeping that steady dose of low B cells, whereas something like rituximab takes them out all out, and then over 6 months they start to come back. So people can kind of flare up during that last 4 or 5 months, but you have to wait till the 6 months to get it again. So this has a lot of advantages to that. Dapirolizumab is another one. This is the Phoenix Go trial, and they're looking at the BICLA response, which is just another way to look at how active a patient's lupus is. Their endpoints were at 24 weeks and 48 weeks, and so you can see the active drug in the dark blue versus the placebo. There is a significant difference at both of those time points of essentially people doing better with their lupus. The way this one works, it's a novel humanized FC pegylated conjugated Fab fragment, um, which works by lowering the activated T cells. Essentially, this one's a little bit harder to explain, but it works. But that's one of those that works between the interaction of the B cells and T cells, and then other cells that create inflammation. And so this one's a little bit harder for me to understand and explain, but it is really exciting. Their results are actually quite impressive. And it just really works as well to decrease the B cell activation and then decrease some of those interferons, which are inflammation mediators. So this trial is in phase 3. They already did one phase 3 trial, and now they're just doing a second one because they want a lot of good data to present to the FDA to try and get approved, which I think is a great idea. It's actually one of only 3 biologics to report positive phase 3 data yet. So the 2 that have already been approved, and then this one. So I think this one has a really good chance of getting approved. This trial is currently ongoing as well. And then I think this is one of the last ones I wanted to present to you, nipocalimab. This is a really interesting molecule. They're looking at for a few different disease processes like Sjogren's and lupus. And this one works by binding to the FC receptor, which protects something called immunoglobulin G. Immunoglobulin G also works by causing inflammation in the body. And what this does is reduces the antibodies because it causes those IgG antibodies to be taken up and degraded so you don't have as much in your body. I have to move my camera to see all these words. So unlike these sort of broad immunosuppressants, this one specifically targets IgG, which is a little bit more precise. So you can kind of calm down the immune system, right? So like those JAK inhibitors I started with, the upadacitinib, can work really high up in the immune system to lower levels of a lot of different inflammatory mediators, or you can come down to more and more precise, which maybe has some benefits as far as safety and may work better for some people, some of those, and then other ones might work better for other people because with lupus, everyone's a little bit different. Some people have kidney disease, some people have rashes, lots of different combinations of how your lupus might be active. And I'm sure that different treatments will work differently for different people. So I'm really glad we're going to have all of these options, hopefully, or at least some of them. This is the Jasmine trial with nipocalimab. This is a year-long double-blind trial, and they announced just on January 6th, actually, positive results from their phase 2B study. So again, this is going to be a really exciting one. So I'm sure this is going to be going out through the later phases and trials. A few others I didn't want to belabor on that just to show you how many different things are going on. Deucravacitinib is a TYK2 inhibitor. That works very similarly to those JAK inhibitors, but a little bit more narrow, maybe a little bit better as far as safety. So that's in phase 3, the POETIC trial. There's litifilimab, which is an antidendritic medication. This is going on a late stage study. And then another exciting one, anifrolumab, which is Safnello, which is already approved, is actually doing a trial to look at getting an injection form of it because right now we only have the IV form available. And so if this is approved, then you have a choice of doing either an injection at home or an IV in the office, which I think is really nice to be able to offer more patients different options. And then we're going to wrap up talking a little bit about CAR T cell therapy. And you may have heard about this because it's sort of been the hot topic in lupus for the past few years. What we're doing is looking at those B cells, and with CAR T, sort of taking some of that information we're learning from treating cancers in the hematology world and bringing that over to try and say, can we really take out those B cells in a deep way such that people can maybe be symptom free for long term, maybe even years? I'm going to show you a picture after this. So I think you'll understand it a little bit more then, but just how does this work? First of all, they do leukapheresis to get out some T cells. There's different ways of doing this. You can do it with your own T cells, or sometimes they take T cells from other people. Anyway, they take those and they sort of genetically engineer them. They give them a viral vector. They make those T cells kind of encode that CD19, and then they expand them. They grow a bunch of them in test tubes in the lab, and then they give them back to a patient. But they give the patient almost like chemotherapy. They really take down their immune system before they give them those T cells back. Usually people have to be admitted to a hospital for about a week for this. There's a lot of real safety concerns, sort of like a stem cell transplant where death can be a concern, although done safely. I think we can do it in a safe manner, but this is not going to be for everyone. Anyway, these are a few articles that talk about it, and one published in 2022, 5 lupus patients were disease-free, and some of these patients in these early trials have been, I don't want to say cured, but they have been disease-free for years. And so, like you see in the bottom line here, they've had sustained remission after this one therapy for 24 months, suggesting maybe we can reset the immune system. It's the closest we've ever come. This is a picture of it. So starting at number 1, where they take out those T cells and then they isolate them in a lab. They give them these genetic modifications, and then they grow them, and then they infuse it back to the patient. And the patient has to be lymphodepleted, meaning they kind of go through a program of chemotherapy to get their immune system really down, so that when you get these new T cells, maybe those take over rather than the diseased T cells that you started with. Allo-NK is something that we're doing now, which I think it's almost like I call it, this is my own term, I call it a baby CAR T, because it has the same idea as the CAR T, but it's not quite so strong. You don't have to be admitted to the hospital. It's done as an outpatient. So this is an off-the-shelf therapy. They don't need to take out your blood to be able to do it. It has advantage because for one donor, they can take one donor and use that for hundreds, if not thousands of patients. It's pretty easy for them to replicate that. And it's not genetically modified. They're actually just taking cord blood from people who have this genetic tendency already to respond well to medications that can attack those NK cells. And I'll show you a picture of that. So the company is called Artiva. So you take a patient and we give them a couple of doses of a light chemotherapy to get their immune system down. And then we give them, you can give them any medication, but with this specific trial, we're using that rituximab, the one that takes down your B cells for 6 months. So they get a little bit of chemo, they get the rituximab, and then they get some doses of this cord blood, which programs these NK cells to kill disease cells. So it's the same idea. They're actually studying this for a few different diseases, rheumatoid arthritis and lupus. I think it's really exciting. This is very early in their trials. We definitely don't have any results back, but again, trying to really take the immune system down to a further level than we're able to get with the regular biologics on their own, to maybe treat those really severe patients or just get a more long-term remission. So you kind of go through this process and then your lupus is gone for a few years. I think that's the hope, but we'll see what happens. And then I want to wrap up just talking more about trials. We do a lot of these in our office. It's my favorite part of what I do. I'm so excited. I feel like, I've been practicing for about 20 years, and over the years, I help individual patients, and it's really rewarding. But I found it a little more rewarding to maybe help develop a new medicine that can help thousands of patients all at once, Um, and there's just a lot of people that have tried everything out there and just nothing has worked great for them. So it's nice to be able to offer them some things that maybe they can't get otherwise. Why do people like to do these? Sometimes it's the people like to have the chance to help bring new medications out. Medications, all the testing, all the medicine is provided at no cost when you're in these trials. Everything's given to you for free. They even pay, it's a nominal fee, but it's paying you for your time essentially. They pay for travel costs. It's a chance to learn about the disease and help other people. The next steps, if you'd like to be in a trial, are to talk to your doctors, see if they think the study might be right for you. You probably want to search and find, I'll show you the websites here in a second where the studies are, and then you can find who's doing those trials and then just call them up and say you're interested. And you do have to meet certain inclusion criteria, exclusion criteria. They're looking for a very certain set of people. So sometimes they say can't be over 75 or you can't have had a cancer in the past 5 years, something like that. Every trial is a little bit different. So we have to go through all of those criteria and make sure that people fit that. Questions you might want to ask: what's the purpose of the study? How long is it going to last? Who's reviewed it? What are the possible benefits? Of course, what are the risks of the medications? So for these phase 3 trials, they've already done the phase 2. So we can talk a little bit about safety, any specifics on that medication. You probably want to ask, is it a pill? Is it a shot? Is it an IV? How often will it have to come? How long will it last? And what will happen afterwards? Sometimes they'll keep giving you the medicine for a while. Sometimes it's just 6 months and then you don't get any more of the medicine, but at least you might know if it worked for you. If it gets approved, you could use it again. These are those websites. So the main one is this clinicaltrials.gov. You can go on that. You can put in your disease. You can put in if you want trials that are still taking new people or just trials that may have finished. And then it tells you all about what medicine it is, where they're doing it, what kind of people they're looking for. And then there's 2 lupus specific ones, the lupus therapeutics and lupus research. These have a lot of great information about trials going on, any new research, and how to be involved. There's other ways to be involved other than just being a tester for the medicines. You can be in advisory boards. A lot of times, these groups or maybe the drug companies themselves are looking for people to help them design the trials, because as a lupus patient, you have a lot to offer about how you might want to be treated with the trial or what's important to you, and they want to know those things. They also have people who are on protocol reviews, so you can apply to be in these sort of committees to look at how these trials are going to be designed and what's going to be the protocol for it. So I think those would be interesting ways to be involved. And that's it. What questions do you have?
All right. Well, thank you, Dr. Crowley. That was a lot of information. So we will get to the questions now. So if anyone does have a question, please put it in the chat or the Q&A, and we will get started. We have one question came in already, and it said, if you already had a kidney transplant, are you eligible for a trial?
Oh, that's interesting. Maybe it really depends on the trials. You wouldn't be a candidate for a lupus nephritis trial, most likely, but a transplant. A lot of times it depends on what kind of transplant medicines you're on. So they may not want their medicine to interact with the medicines for the transplant. So I think my answer to that is potentially, if you're interested in a certain trial, it never hurts to ask and review it.
All right. I had a question. So if I know you mentioned like, go to these sites, lupus research, and find if a trial, if you're really struggling. And it would if your doctor doesn't work with trials, or how do you kind of like reach out to someone doing a trial? Do you then give that research back to your doctor, or how do you kind of make sure, because
Yeah.
if you're gonna try new medicine, like then do you stop your current medicines? Like how does that work?
Yeah, so you can do either way. So you can look and see what trials are going on in your area, and then again it would list out. So the trials that I'm doing, you could see, and it has a phone number, and you can just call the site up, whichever site is closest to you. You can call them up and they can, what we do is then we try and get your medical records so that we don't want to waste your time. I review the medical records just to make sure that I think that you would be a candidate for the trial you're interested in, or any other trial that I may have going on that I think might be good for you. And then, yeah, you clearly should talk to your regular rheumatologist, make sure they're on board with it. Usually they are. And then the next step is we set patients up to come in for a screening visit. And so that can take about an hour or two, maybe 3 hours, because we really deeply we go over all the paperwork, make sure people understand they're consenting to. We go over all of their history. We make sure they meet those criteria. We get blood work. And then once we decide, usually about a few weeks later, if they do meet all those criteria, then they come back to start the medicine. It's completely optional. If they ever decide, hey, I'm not comfortable with this, or I change my mind, then that's fine. They go back to their doctor. I hope that answers your question.
All right, a couple more have come in. Is there any research being done on a cure?
There is, and I think that CAR T is sort of the one of the closest ones we're doing now. But yes, research is being done. I think a cure beyond the CAR T is further away, but maybe in our lifetime.
Right. Can you go back to the previous slide for a moment? I think that was the one
Yeah,
with the
this
link.
one. The links. There you go.
Yes. Another question is, who are in the trials? Women, men, white, black, Latina, Asian?
Oh, that is a great question. It depends on the criteria, but we really do want to get a wide variety. We don't want all of our trials just to be with white men, because they may not respond the same to medicines as different nationalities, women versus men, young versus old. So the ideal way to do it is with a really good mix of people.
All right. Any other questions or comments? Let me see. There's one coming in. The other slide with other ways to participate.
And the information about this one is on one of those bottom two links. I got this specifically off of those. Oh, actually, you can see it at the bottom. It's the lupustherapeutics.org. I'm sure there are other ways to be involved. I think this one would be an easy way, and I found this online.
All right. I think that. I want to make sure I got all of them. Oh. What new lupus meds are you most excited about?
Oh, I think the first couple that I talked about. I'm really excited about the Benlysta B early trial, even though that's already approved. I think we never had a trial like that, so that's going to be excited. And then the obinutuzumab, obeleximab, ianalumab. I think those the ones that I picked out to tell you about. Those 4 or 5. That's why I picked them.
How do you, as a doctor, without, I don't know if you have lupus or not, but any of these diseases, how do you guys hear about these drugs and these trials? I mean, are you constantly doing your own research or do they reach out to the doctors? What's that
So,
process like?
well, I'm sure it's different for different people, but I've been working with these companies for 20 years. I know the scientists in the companies, so once I do one trial with a company, then they know that we do a really nice job with them. So they always come back to me to say, hey, we have a new trial coming out. We have a new drug. We'd like you to be one of our sites that test this for us. Um, and then I just really like to be involved. So anytime the companies call, I maybe help them design some trials or give them advice. And so it's really sort of a relationship that I have with the companies, because I feel like I don't make drugs in my office, so the best way to get them to you is to work with the people who do. Some of the academic centers do trials just sort of because of their reputation, and they've been doing these trials for longer. Now, the academic centers they may be doing some of their own trials that aren't necessarily sponsored by the drug companies. I do more of the drug company trials, like the new medications coming out. At the academic centers, you might see a more wide variety of different kind of trials, maybe some more of those registries or observation ones, or comparing two different medicines that are already out, something like that.
Another question that came in, are there any red flags to clinical trials? I've heard stories about doctors asking for blood or getting history before the patient knows what they are signing up for.
Right, that is a red flag. You should definitely sign a consent before anything else happens. Yes, definitely. If it's, if it's my clinic patient, there's a little bit of a gray line just because I might have already examined them or gotten blood in the clinic before.
Mhm.
But when it comes to the trial, I actually did it this morning. I'd seen a patient in clinic who wanted to do one of my trials. So we moved her to a different room. She spent about an hour going through the consent form, signing the consent. I went back in and did another exam because that's the exam for the trial. And that has to happen after the consent, not the one, I can't use the one I did from before. So the FDA is very clear on exactly how these things have to happen. So, right, if you don't know someone and you go in and they start doing any sort of exams or blood before you sign a consent, that is a red flag. Yes, for sure.
All right. Does anyone else have any last minute questions? I think I can open. All right. Well, I think we will wrap up then. So I just want to
Okay.
thank you again, Dr. Crowley, for this presentation. It was great. It's very exciting to see so many people on tonight and learning new things. I think we're always excited for new treatments, new ideas, new opportunities. I think, anytime we see a commercial about a lupus drug, I think, that's very exciting for people with lupus. So knowing that there are some medications in trials and knowing that lupus has become more of a topic in the pharmaceutical community, I think that's really great. So many people are chatting. Thank you. So thank you from everyone that was on the call. They really appreciate it. Again, this is being recorded, so this will be archived on the website in the next couple days. And so if anyone missed anything or wants to go back and watch or share it with anyone, please do. You can always reach out to me or Mary at the LSI office if you want to get in touch with Dr. Crowley or have questions about research and opportunities. Dr. Crowley or anybody on the call can reach out to us. We're, happy to help and assist with anything like that. So again, thank you so much. And I just want to remind everyone that we have our walk, save the date. We hope to see everyone on August 22nd in Naperville. And besides that, we will have some more other events coming up soon. So stay tuned. Make sure you are signed up for our emails and check our website, social media. We post a lot there as well. So thank you so much again, Dr. Crowley. Thank you so much. And everyone have a good night.
Thank you. Bye.
Bye.